I'm very honored and humbled to be here speaking.
So we can hear you.
I can hear him fine.
Was that take my mask off? Is that what I heard? Okay, because I couldn't hear that. Okay, thank you. I'm very honored and humbled to be here today, and so thankful that we could meet here in person and have some medical education. I'm going to talk about some of the more common and infectious things that I see in clinic, and also a recently worrisome virus that, for you astronomy junkies out there, does not even have any close way of rhyming with COVID. And I work mostly in private practice, as Brian said, and I will be discussing some off-label uses of medications, but I have no conflicts of interest. Let me see if I can figure out how to advance this. There we go. Okay. So, meteor showers are one of the things that I love about Utah. The dark skies that we have here, all the national parks. My wife will tell you that I love astronomy. I frequently stay up late to watch meteor showers and lunar eclipses and stuff like that. She even bought me a telescope for Father's Day last year. And this month, as we go into fall, there are many things that I love about Utah. Two of those meteor showers are coming up, the Draconid and the Orionid. And both of those kind of rhyme with COVID. We had a new moon yesterday, and the Draconid shower peaks in the early evening tomorrow with about 10 meters per hour. It could be a very spectacular meteor shower. But like the Zika virus epidemic we had in the last few years, it should be short-lived, so you don't have to stay up too late to watch it. And if meteors just aren't your thing or the weather doesn't cooperate, we have 3 major college football games this weekend. Weber State has one tomorrow at 8 p.m. Here in town. And also, if you haven't had the chance to drive up Ogden Canyon, my family and I did that last night. I've done it several times. It is one of the best drives for looking at fall foliage in the state, and I highly recommend you do that if you haven't had the chance to do that. Here's a photo of some of the foliage you can see in Ogden Canyon. It's a little pixelated, but I hope you get the picture. Really, Utah is a beautiful place to live in, and I'm very excited to be back in my home state. I was raised here. Now to the business of the hour. These are my objectives. And to begin, I'll talk about acne vulgaris, one of the more common things for which people see physicians, because its treatment frequently involves the use of antibiotics, and it has several infectious mimickers, one of which we'll discuss today in detail. I'm going to talk a little bit about acne. It's influenced by the colonization of Cutibacterium acnes, formerly Propionibacterium acnes, and it can be complicated and mimicked by infectious diseases. Antibiotics are a very common therapy, both oral and topical, and overuse is a very big concern. The 2016 guidelines for the management of acne vulgaris from the American Academy of Dermatology have important points regarding the antibiotic stewardship that we all have, that have become the current standard of care and are important for our ability as a society to offer and appropriate and useful therapies for infectious disease to ourselves and future generations. Acne affects about 50 million people in the United States, including 85% of teenagers and 12% of adult women. It can cause poor self-image, scarring, depression, and anxiety, and has direct costs exceeding $3 billion per year. The main 3 causes of acne, which must all be present for acne to occur, include colonization with C. acnes bacteria, follicular hyperkeratinization, and sebum production, which is influenced greatly by hormones such as androgens, and that significantly increases around puberty for most kids. All those things, including the type of C. acnes bacteria that we're colonized with, are influenced by genetic factors which influence the complex inflammatory and neuroendocrine regulatory mechanisms that determine a patient's acne type and severity. And non-genetic factors such as diet and environment are also involved. This is a summary slide of the 2016 Guidelines for Management of Acne vulgaris from the American Academy of Dermatology. And it's subdivided into mild, moderate, and severe disease. And treatments vary for each type of acne. I'd like to draw your attention to the fact that treatment with antibiotics, either topically or orally, is included as a recommendation for every type of acne. Because of this, and because of their vital role at treating infectious diseases, I'd like to highlight what the guidelines say about using systemic antibiotics to manage acne. First, systemic antibiotics are recommended in the management of moderate and severe acne and forms of inflammatory acne that are resistant to topical treatments. Doxycycline and minocycline, which are in the tetracycline class, are more effective than tetracycline, but neither is superior to each other. Submicrobial doses may be useful, such as 20 milligrams of doxycycline twice a day or 40 milligrams daily, but are not superior to standard dosing. And although oral erythromycin and azithromycin can be effective in treating acne, their use should be limited to those who cannot use the tetracyclines, like pregnant women or children less than 8 years of age. Erythromycin should be restricted because of its increased risk of bacterial resistance. And regarding the use of systemic antibiotics other than these, the tetracyclines and the macrolides, they're typically not recommended and discouraged because there's limited data to support their use in acne. Trimethoprim sulfamethoxazole and trimethoprim should be restricted to patients who are unable to tolerate tetracyclines or in treatment-resistant patients. And the next point is what I really want to drive home, because I get a lot of patients in my clinic that have been on antibiotics for a long time. And the current guidelines from the American Academy of Dermatology say that systemic antibiotics should be limited to the shortest possible duration, typically not more than 3 months. So in my personal practice, I rarely put any patient on systemic antibiotics for more than 3 months. Monotherapy is strongly discouraged. You should always treat acne, if you're going to use systemic antibiotics, with topical retinoids or topical benzoyl peroxide. If you go back to this summary slide, all that data is in there. And if you want to Google the 2016 Guidelines for the Management of Acne vulgaris, all that information is in that article. Went too far. The Academy of Dermatology does recognize that there are a subset of patients for whom systemic antibiotics for longer courses may be required, but they should be monitored very closely, and it's actually discouraged. So I always tell my patients they shouldn't be on antibiotics for a long time for acne. We have many other treatments, and that can really help us fulfill our stewardship of the antibiotics and be able to treat infectious diseases with more wisdom going into the future. So I just wanted to highlight that. And what do the guidelines say about microbiologic testing? Well, it's not recommended, except in cases not responding to conventional therapy or when a mimicker is suspected. And there are several mimickers that we see. One that I'll talk about more in detail today is gram-negative folliculitis. There are many others. I just don't have the time to go into everything, so we won't cover pittosporum folliculitis, Staph aureus folliculitis, or some of the other conditions that are mimicked by acne. But gram-negative folliculitis is actually quite a common thing that I see. About 80% of these patients will have superficial pustules, comedones, and papules. It's usually caused by organisms such as Klebsiella, Escherichia, and Serratia species. Another 20% of patients with gram-negative folliculitis will get nodular and cyst-like lesions that look like nodulocystic acne. It's usually caused by Proteus species, which can cause deep abscesses and cysts and get into the tissue deeply. Hot tub folliculitis, which is caused by Pseudomonas most often, is also included in this group. But that's usually a self-limited disease that resolves on its own. If it doesn't resolve after several days, you can recommend dilute vinegar baths to the patient or direct the therapy as per the culture results. These are just some typical photographs taken from DermNet NZ of a patient with gram-negative folliculitis. You can see it mimics nodulocystic acne. Usually in the deeper ones, it's focused on the cheeks and around the mouth and nose. The picture on the right is a typical example of hot tub folliculitis. As I mentioned, that's usually self-limited and goes away on its own. Diagnosing gram-negative folliculitis requires a level of awareness and suspicion of the potential diagnosis and is confirmed with culture of the typical lesions. Treatment is directed by culture. And in the past, this was frequently done with fluoroquinolone antibiotics. In my training, that's what they always told me. Gram-negative folliculitis, give them a fluoroquinolone. However, fluoroquinolones have fallen out of favor recently because of the black box warning the FDA has given to them, which they now carry for tendinitis and tendon rupture, particularly of the Achilles tendon, for myasthenia gravis, and for permanent peripheral neuropathy. The FDA also warns that fluoroquinolones carry the risk of mental health side effects, serious blood sugar disturbances, and disabling and potentially permanent side effects involving tendons, muscles, joints, nerves, and the central nervous system. That was taken from a FDA news release on fluoroquinolones in 2018. So, if you have one of these patients, the most common choices for treating this is trimethoprim, sulfamethoxazole, or ampicillin, and of course that's driven by the culture results. So it's very important to take a culture if you have a suspicion that your patient may be suffering from gram-negative folliculitis rather than acne. Isotretinoin suppresses sebum production, and it dries out the nasal mucous membranes where these organisms are usually harbored, and so that's also a very useful choice that doesn't involve antibiotics that can treat gram-negative folliculitis as an infectious disease. So if a patient presents with acne-like lesions that are resistant to standard acne therapy, they're persistent or progressive despite typical treatments, a referral to a board-certified dermatologist experienced in diagnosing and treating this infectious mimicker of acne can be of great benefit to the patient. The next group of infectious diseases I'm going to talk about is, they're all caused by viruses. Some common ones like human papillomavirus and the molluscum contagiosum virus, and a recently worrisome epidemic caused by the Zika virus, which hopefully we're kind of past that. I do think it's ended if you look at the data from the CDC. Human papillomaviruses first. They're a group of highly prevalent DNA viruses. There are over 200 total types. 42 million people in the United States are infected with this, and more than 13 million new infections occur yearly. Something I see a lot in my clinic, one of the most common infectious diseases. The virus resists heat and desiccation. It's quite contagious. It can spread via skin-to-skin or skin-to-surface contact. And fortunately, 90% of the infections will clear on their own within 2 years. However, some persist indefinitely without treatment and can be associated with malignant changes. And there are a lot of malignant changes caused by this virus. Every year in the United States, HPV causes 36,000 cases of cancer. And that could be a huge underestimation because beta types, would include HPV type 5, 8, 9, and many others, have recently been implicated in causing cutaneous squamous cell carcinoma, together with the effects of UV radiation, which is something I deal with a lot. HPV, the high-risk types, have been known for many years to cause cervical, vaginal, and vulvar cancer in women, penile cancer in men, anal and oral pharyngeal cancer in both sexes, and nearly 2,000 women are diagnosed with cervical precancers, 11,000 women with cervical cancer, and 4,000 women die of cervical cancer every year due to HPV infections. Here's a table from the CDC showing the specific types of cancers and their statistics for their yearly incidence. I'll just give you a minute to look over that. And thankfully, there are several vaccines that have proven to be both safe and effective at preventing most of these cancers. I don't want to go into a vaccine debate, but I am very pro-vaccine. I think if we look at the evidence, vaccines help us so much. Specifically for the HPV vaccines, there are at least 3 that have been developed. The nonavalent vaccine covers HPV types 6 and 11, which are the most common cause of genital warts, and 7 of the most common high-risk HPV types that lead to cancer in both men and women. It's approved now from ages 9 to 45. And the dosing schedule includes 2 doses, 6 to 12 months apart, for those who are younger than 15 years, or at least if they get their first vaccine before their 15th birthday. For those who get their first vaccine on or after their 15th birthday, it's a 3-dose regimen, with the first dose on day 0, the second dose 1 to 2 months later, and the third dose 6 months after that first dose. And everyone is recommended through age 26 should get the HPV vaccine if they're not fully vaccinated already. And some adults, ages 27 through 45, who are not already vaccinated, can get the HPV vaccine after speaking with their doctor about the risks and benefits. In particular, I want to just emphasize that healthcare workers, all of us, our staff, anyone that really deals with HPV, it's recommended they get the vaccine. That includes dermatologists, obstetricians and gynecologists, emergency physicians, family physicians. It's now recommended through age 45. So if you deal with HPV, I would encourage you to encourage your staff and yourself to get the vaccine. This vaccine, the 3 of them, actually, because many studies have been done, not really studies, but studies, but case control series, and even just some case series without controls, like this one. Out of Egypt, this one came out a few years ago. It showed this vaccine can be used for treating infectious diseases. So, this was a series of 44 adult patients with multiple recalcitrant common warts, present for over 2 years and not responsive to any of the standard therapies like cryotherapy, injection with Candida, et cetera, et cetera. It was broken into 2 arms. One group received the bivalent vaccine, which was just for HPV 16 and 18, at the standard schedule, 0, 1, and 6 months, and they received it intramuscularly. The other arm received it intralesionally, 0.1 to 0.3 milliliters of the bivalent vaccine into their largest wart at 2-week intervals until complete clearance or for a maximum of 6 sessions. They were followed every month for 6 months, and the intralesional arm had 82% of their 82% had complete clearance of warts, and in the intramuscular group, 63% were completely clear. Adverse effects were transient and insignificant, and there was no recurrence reported in either group over 6 months. Here's just a photo of one of the patients in the intralesional arm who cleared after 4 sessions. And you can see on the top picture, that's the first one. The second one is after 2 sessions, and C is after 3 sessions. You can see complete clearance of these warts. This is another study out of Korea with 45 patients in a single arm with no control. They received the nonavalent HPV vaccine according to its typical schedule, 0, 2, and 6 months. And they defined recalcitrant warts as those persisting more than a year and not responding again to 2 conventional therapies. And they found about a 62% clearance completely in their patients of warts. And, you know, these studies, none of them have had a control, and warts sometimes do go away on their own, as we know. But it's just interesting to note that the HPV vaccine may be a therapy that we can use for infectious diseases. More studies need to be done, but these series show that this could potentially add another effective and safe therapy to our armamentarium for recalcitrant warts. If a patient has warts, not responding to standard therapies, consider a referral to a board-certified dermatologist to explore whether HPV vaccine therapy could be appropriate and advantageous for the patient. Molluscum contagiosum is another common infectious skin disease that I see. It's caused by a double-stranded DNA virus in the Poxviridae family. And with the eradication of smallpox in 1980, it is now the only pox virus that specifically infects humans. There are 2 types MCV1 and 2, and they cause indistinguishable lesions. It can be spread again by skin-to-skin contact or by fomites. It's very common in children. I see it so much. It's a self-limited disease, and most patients will clear within several months to years, even without treatment. It's also seen in adults, usually as a sexually transmitted disease, usually in those who are immunosuppressed, and most notably those who have HIV. But I see it in other patients as well, in adults who are not immunosuppressed. I want to point out a few studies that influence my treatment of this common infectious condition. The first is a retrospective case study done in Baltimore at Johns Hopkins by telephone interview 2 to 5 years after the diagnosis of molluscum. This survey found that 50% of patients had complete clearance of their skin within 12 months of the diagnosis. 70% cleared within 18 months. Treatment did not shorten the time to clearance. I keep copies of this study in every room in my clinic, and I hand it out to parents of my patients after discussing the various treatment options so they can make an informed decision about what to do about this infectious disease. Still, some parents and guardians insist on treatment for molluscum contagiosum. This is a slide detailing the reasons they usually seek treatment. This is from a study reported in 2000, I think it was 2020, I think it was this last year, in the Journal of the American Academy of Dermatology. Oh, it's 2018. The bottom of my reader is cut off, so I can't read it. So they said increasing number of lesions is the most common reason they seek treatment. Itching, the patient's picking at the lesion, or they're embarrassed by them. Those are the most common reasons they seek treatment. And I won't go through the details, but this study showed that cantharidin, 0.7% solution, is safe and effective for facial molluscum contagiosum lesions and results in few adverse effects. 94% of respondents said they would recommend cantharidin again for facial molluscum lesions. And when I was trained, I was told cantharidin is great for treating molluscum other places, but we shouldn't use it on the face. This, I think, is a game changer, and we do use it on the face frequently now. So if patients do want treatment, that's a great way to do it. You just have to be careful and to follow the recommendations that are in this study for when to wash it off. It's a little bit earlier, about 1 to 2 hours later. Another potential treatment that has the ability, or demonstrated the ability to clear molluscum contagiosum infections is the pulse dye laser. I've listed a few of the studies detailing its effectiveness here, and if a patient or their caregiver asks for treatment for molluscum, cantharidin and pulse dye laser therapy are two of the better tolerated treatments. Of course, this needs some pre-treatment numbing that many board-certified dermatologists have available in their clinics at their disposal to treat this infectious disease. And now for my final topic, which I hope is a good break from all the fear and worry we may be experiencing about the current COVID pandemic. Somehow we've seemingly beat the Zika virus pandemic. Here are the numbers of cases in the US and in Utah over the last 7 years for this epidemic. You see it peaked in 2016, which is when I traveled to an area with Zika virus with my wife. So we were very worried about that, but in 2021 there's only been one reported case in the whole United States. So is it over? Zika was first described in the 1960s and is similar to the dengue virus. It can be transmitted by bites from the Aedes aegypti mosquito, which bites during the day, from mother to child, and sexually. It has around a 10-day incubation period between infection and the development of symptoms. And here's a picture of the Aedes mosquito taken from the CDC's website on the Zika virus. And if there are any residents or medical students out there, the way the Aedes mosquito is distinguished in photos from other mosquitoes like the Anopheles is due to those white bands that you can see on its legs and abdomen. At least that's one of the easy ways to do it. How I remember that is I think of stonewashed genes were common in the 80s. That's an Aedes mosquito. Okay? So, and that was on my boards. So what kind of mosquito is this? And it may be on infectious disease boards too, I don't know. So the typical common symptoms are listed here and include headache, mild fever, chills, conjunctivitis, arthralgias, myalgias, and an itchy morbilliform rash. Other potential symptoms include dysesthesias, dry mouth, skin and eyes, and bladder incontinence. Most infected patients recover within a week. The rash starts on the first day of illness, usually on the face, and spreads to the trunk and limbs. It can affect the palms and soles. It starts to fade after 2 or 3 days and is gone within a week. Here's some photos of the typical findings on the mucous membranes and skin, including conjunctivitis and a morbilliform eruption. Here's some other typical photos of the skin showing the morbilliform eruption on the trunk. One of the main concerns with this virus is its ability to induce severe birth defects, including those listed here. It can also cause Guillain-Barré syndrome. And for diagnosing Zika, there are no current outbreaks, and dengue cases outnumber Zika by 200 to 1. No testing is recommended for non-pregnant patients. If you have a symptomatic pregnant patient who's traveled to an area of dengue with a risk of Zika, they should get serum PCR for dengue and Zika and urine PCR for Zika. IgM testing should be done for dengue only. Zika virus IgM testing is not recommended for symptomatic pregnant women because, for one, the IgM levels can persist for years, and so it's not known whether a high IgM is indicative of a recent infection or not. There's also some cross-reaction between dengue IgM and Zika IgM. So if you have a recent dengue infection, your Zika IgM might be positive, so that's not recommended. And then treatment, there's really no specific treatment. It's usually self-limited and resolves with supportive therapy. Acetaminophen can be used for patients with fever. Aspirin and nonsteroidal anti-inflammatory drugs are not recommended because of their risk of increasing bleeding. You should drink plenty of fluids, rest, and avoid blood donation, and then wear DEET. Protect yourself from mosquitoes because you can spread it to other people. Okay, those are my references. Thank you for your attention. We have a few minutes now, I think, for questions, if there are any. Okay, thank you.